But Dr. Cypel, a staff thoracic surgeon who we all know well from the Toronto General University Health Network, assistant professor of surgery at U of T, many accomplishments under his name, not the least of which is his work with EVLP and lung assessment prior to transplantation. A colleague, friend, expert, welcome.
Thanks so much, Andrew. So we're going to talk a little bit about this new project we started a few years ago, and it's basically what we call non-perfused organ donation. I'm going to give a little bit of background on that. You know, a lot of this work, and I think probably Andrew should be presenting here today, but I'm going to give a little bit of the perspective on the transplant side of things, but a lot of the work was done really on Trillium and William Osler systems. Talk a little bit about the protocol of NPOD and the initial transplant experience and some of the next steps we're thinking right now on this. I think we're all familiar with this types of donation. And the DCD specifically, as you know, there is the control DCD where there is a planned withdrawal. And then there is the unexpected death, which we call uncontrolled DCD. And we called a term here NPOD, which it's a little bit more similar on the side of tissue donation, explain why. The use of uncontrolled DCD has been mainly practiced in Europe, specifically in Spain, but also some of the other countries like Italy and Netherlands have also practiced that. You know, whether NPOD is similar or different to that process, there are some differences. I think certainly we're talking about Maastricht category 2 here, where there is unsuccessful resuscitation and uncontrolled DCD scenario, but perhaps the main difference between the NPOD and the typical uncontrolled DCD is that there's really no measures to restore circulation after death declaration. So if you look at the Europeans' uncontrolled DCD protocols, there is restoration of circulation by normothermic regional perfusion of the organs or continuous cardiac massage, and this can occur even before family consent. So very different from that standpoint in terms of the simplicity of the approach on the NPOD process. So I think one of the key questions for us was whether the lungs can tolerate periods of no perfusion, right? Which we call warm ischemia, right? So this is the true warm ischemia where there is zero blood circulation at that point. And the answer for that is yes. If the lungs are maintained inflated with oxygen, the lungs cells can stay viable for a few hours. So Tom Egan in the early 90s, he wrote this paper after done some studies in rats, evaluating that, and he was able to show that actually the lung does not die when you die. And in his studies, both in small and large animals, he was able to show that up to 3 hours, if you keep the organ ventilating or inflated, the quality of the cells were still viable for most of them. So we evaluated this process more recently. This is a porcine model of warm ischemia. So basically, we draw life-sustaining measures here in the model, and about 20 minutes later, the animals go to asystole, and then basically we waited 0 hours or 2 or 3 hours before retrieving the organs from these animals. And you can see here that up to 2 hours at least, the lung viability was quite good, with 100% of these lungs performing well on ex vivo lung perfusion, and a lot of variability on the 3 hours, with some organs okay, some not okay. But that created the basis for establishment of the NPOD protocol, which again, as I mentioned initially, there was quite a lot of work on this from the donation side. And I'm not going to go through all these boxes here, but some, I think, important concepts. Basically, you have a failed resuscitation after a cardiocirculatory arrest, and then you have the termination of death. This determination of death occurs in a hospital setting. There is a rapid referral and limited assessment, and then the opportunity for organ donation, in this case for lung donation only, and consent, and then organ procurement. And the timelines we set on this was up to 90 minutes to obtain consent from the family, and up to 3 hours to have our team flushing the organs with a cold preservation solution. And the reason we set to the 90 minutes for consent is if you don't get consent in 90 minutes, it's very unlikely that you'll be able to be retrieving the organs within 3 hours. And so that was a stop point. So these were some of the questions in the screening. Whether the donor had ages between 16 and 65, the cardiac arrest had to be witnessed, or the patient had to be seen alive less than an hour prior to the cardiac arrest, and rule out asthma and COPD, or history of cancer. So some of these are even a bit more strict than our general donor criteria, but we really were looking in this initial experience to be very selective. So going in a little bit more detail, so you have an unsuccessful resuscitation, and MRP documents the time of death, and they initiate the NPOD screening tool. And if this donor was intubated, the respiratory therapist would apply the NPOD device, which I'm going to show to you, but it's basically a CPAP machine with 20 centimeters of water. And then Trillium is contacted with the referral, and then at that point, Trillium will collect the available information and call our team at UAGN to see if there was interest. If there was interest, then the family would be approached, and this would have to happen in 90 minutes, so not a lot of time for that. And once there was some agreement to proceed ahead and consent was obtained, then the lungs were recruited, and more recently we started proning also these donors. I'm going to show you a little bit of that. And then transferring the donor to the OR for the organ retrieval, and all this process would have to happen in 3 hours. This is we call the NPOD, basically device, which basically is a CPAP device that keeps the lung inflated at a set pressure with an inspiratory fraction of oxygen of 50%, which is the ideal scenario to maintain cell viability in the absence of any blood circulation. One of the challenges that we have is, although Brampton Civic Hospital and Etobicoke, they are not far away from Toronto General Hospital, depending on the time of the day, there could be a lot of traffic and take us more than an hour to get there. Because we didn't have functional assessment of these organs like we have, for example, in NDD donor, all of these donor lungs that were considered for transplantation, they were placed on the ex vivo lung perfusion system. I'm not sure how familiar you are with that, but basically this is a functional system of the lung outside the body that you can assess the lung function for several hours. And determine the quality of the organ prior to transplantation. We used this device in 100% of these potential donors. And just to show you that this method of lung assessment is widely used in our program since 2008, and it basically allowed us to increase lung transplant numbers to 100% increase in activities, with doing about 200 lung transplants every year. And about 30 to 40% of these transplants are performed with lungs that were assessed on this device. In terms of the outcomes that we wanted to look at, the most important outcome in early time points is primary graft dysfunction. and we wanted an expected rate, a rate less than 20%, which is normally we see in a range of 10 to 15% in our usual transplants, and then secondary outcomes as delineated here. So in about 3 years that the study it was opened, we had 147 referrals, and out of these, 44 families were approached, and there was a lot of exclusions here because of medical unsuitability, or there was no interest from the transplant program, or there was no resources to approach at that specific time, for example. And it was interesting for us to see that almost 70% actually of the families consented for organ donation, even though this was a very rapid situation and very stressful for the families due to an unpredicted death. So out of these 30 consented donors at this point, 16 of those were recovered, or at least our team went to the recovery process, and we recovered 11 of the 16 lungs, and they were 2 of them basically were felt unsuitable in the operative room, in the donor operative room, and 9 were put on the ex vivo lung perfusion system, and then 5 of those were selected for transplantation. So this is just a bit of a summary of our recipient data. So you can see here that the mean warm ischemic time was just short of 3 hours. The median age of the recipients was about 50 years old. And the outcomes of these patients have been really excellent, with a median ICU stay of 5 days and a median hospital stay of 17 days, just in comparison with our general lung transplant population. Our median hospital length of stay is 23 days. So they stayed less in hospital than our usual transplants. We did not observe any primary graft dysfunction grade 3 at any time point after transplantation, which was really excellent. And 4 out of 5 of these patients are still alive with median survival of 291 days. We had, and the other important factor here is they all have preserved lung function without any chronic lung allograft dysfunction, so no chronic rejection episodes we have seen in any of these patients so far. We had one patient which was very sick going into transplant. He was on ECMO for about a month. He had a previous cardiac arrest prior to transplant, and that patient had a complicated post-transplant outcome, although with a functioning lung, but he died of ischemic gut 100 days after the transplant. Just to show you a few examples, so this is an example of one of the lungs, and many of you haven't seen lungs before, but these lungs look really absolutely perfect without any injuries. And one of the things you have to keep in mind here too is similar to, in some ways, to the MAID population, but even more so in this population, these are usually healthy people that had a sudden event and died, so they are not in an ICU on mechanical ventilation, which cause a lot of pulmonary inflammation or infection due to ventilation-associated pneumonia and barotrauma and so on and so forth. So I think there is a lot of potential to generate even better outcomes from this pool of donors. And you can see here that this patient did very well. He was actually extubated to room air in 12 hours after transplantation, which is something we almost never see. So one of the challenges, if you consider, is that our utilization is still low. So we're really looking in about 15% utilization rate out of the consented donors here. And what can we do to improve on this? We think that one of the challenges we had in the beginning was taking too long for us to obtain consent, and during the time that there was no consent, we could not do any intervention. And so doing a inflation of the lungs before even having consent for donation was something that was changed more recently in the protocol and accepted by the ethics committee from both hospitals. We also start adding donor prone positioning. This only happens after donor family consent. And I think ideally we should be able to work on a larger time frame. I still think being restricted to 2 to 3 hours it's a big challenge, and maybe we can expand this to more 6 hours, which will make a huge difference. As you may know, when we cool down an organ, specifically lung, they are viable for about 12 hours easily. So if we could perhaps cool down the organ inside this potential donor, I think we would be able to expand that time a lot longer. And then finally, many of these donors, the team went on site and we end up not using because there was some evidence of aspiration which occurred during the process of resuscitation, and perhaps a pre-screening bronchoscopy could provide information in the early time points before going through the whole process until the operative room. This is just a recent study to show, also done experimentally, but using the same model of, after absence of circulation, can you improve the quality of the organ? And just by doing a prone positioning, actually improved a lot the quality of these organs. And you can see here the gas exchange function of lungs and this is after the lung was retrieved, was a lot better when the donors were prone versus in supine position for all parameters of lung function. And you can clearly see here in the pictures the appearance of the lung when was prone versus supine, a lot less inflammation. And this is just a method of cell death measurement, a lot less cell death, which are these red dots here in the prone mode. So I think the main message is that NPOD or uncontrolled DCD is really possible for lung donation. I think that's the main message out of this, and it does work and leads to excellent patient outcomes. And this is really the first lung transplant experience using uncontrolled DCD in North America, and I would say probably the only or the first uncontrolled DCD in Canada for any organ, right? So I think it's really important. Just to put you in context, when you look at our use rate, okay, only 15%, only 5 transplants out of 30 consented donors. When we look at these data from the United States, they had 502 referrals. Lungs were recovered from 31 donors. And basically, after all the exclusions here, they had 0 transplants. Okay, so I think we're doing a lot better that they were doing there. And I'm not going in detail all the reasons why they couldn't get a single organ for transplant here, but I think we're doing a lot better. And I think there's a lot of room to improve still. So what have we learned? I think the consent rate is high and the utilization is still low, and we can improve on that. I think we can discuss later about some of the challenges of the engagement of the emergency physicians, death investigator, and OR during this process that has to occur very rapidly, and the emergency donation is really challenging. And there are some significant implications also in the post-DCD and time declines. And so what are the next steps? So I mentioned to you, on the research side, we're looking at strategies. How can we preserve these organs better after absence of circulation so we can expand the utilization of these organs? But we also think this approach can be quite helpful for the controlled DCD process when the donors do not arrest within the 2 or 3 hours. And as we've seen today here, about 35 to 40% of the donors actually do not arrest in a suitable time frame for organ donation. And I think we can use many of these lungs or lungs from these potential donors. So what we envision here is actually whether we can apply this protocol for a consented DCD when they arrest, like, let's say, 6 hours later. So, the team is no longer there. There is an arrest at 6 hours later or 8 hours later, and at that point, the NPOD protocol is activated, which means reintubation, lung inflation, prone position, call the team. The recovery team goes to the hospital and does the organ retrieval. And we actually have performed a case like that. And so this is a DCD donor that did not arrest in 2 hours. And our team left the hospital. And when they were coming back to TGH, we got a call, the donor arrested just now, are you still interested? And at that point, we already had the NPOD protocol going on, and we say, yes, we're interested. So the NPOD protocol was activated, the donor team returned to the hospital, and then 2 hours later, because the OR had to be reassembled, and take some time, and this was about 4 hours and 15 minutes after withdrawal of life-sustaining therapies and 2 hours of no circulation. The lungs were recovered. Again, we checked these organs on ex vivo lung perfusion, and we performed a bilateral lung transplant with very good lung function after transplantation. So just going back, I think this is very applicable to DCD. It may be applicable for MAID donation at home as well as a principle. This is just X-ray of this immediate post-transplant this patient. So as I mentioned before, this was really a team effort, and many members from William Osler, Trillium, and UHN were involved to make this happen. So thank you very much, and I'm happy for any questions. Okay. So I think before the question part, I would like to welcome Mr. Eric Celentano. Did I pronounce right? Celentano. So Eric was very kind to, I just called him very recently to be present here, but he's one of our patients that received a lung from one of these donors. Has been an amazing advocate for organ donation, and as you'll see, he's doing extremely well. So we invited him to say a few words here to show the impact of this program to our patients.
I had to write this down because I'm going to summarize 7 years into about 3 minutes. Good to speak to you this afternoon. Today is actually my 11-month anniversary of my surgery that was performed by Dr. Cypel. I didn't know anything about NPOD until today. So this is all. So I guess I'm one of the 4 of the 5, right? Learned a lot today. I didn't realize it was going to be so emotional, though. I was diagnosed in 2012 with idiopathic pulmonary fibrosis at age 55. I was initially quite asymptomatic, but over the next several years, my lung function decreased substantially until I started on pirfenidone in 2014, which stabilized my condition for the next 3 years. During that time, however, many of the activities that I enjoyed doing, I had to give up, and physical activity was becoming difficult. I was prescribed supplemental oxygen in 2017 for exercise, further limiting my ability to do anything outside a controlled environment, which was mostly my gym and my condo where I live. I could take my tanks down there and exercise. In the 4 to 5 months preceding my transplant in 2018, my dependence on supplemental oxygen increased to the point where it was needed for almost all routine activities around the house, cooking, showering, anything, but pretty much everything except sitting around watching TV. My life was indeed limited to looking after myself and being rather inactive in terms of work, sporting activities, or travel. I retired from work 4 years ago just because it was too much. After my transplant on December 11, 2018, and my 3-week hospital stay, I began an extensive rehab program under supervision of the physiotherapy team at Toronto General Hospital for the next 3 months. During that time, my fitness gradually improved, and I was able to get back to being much more active than I was before surgery and did not rely on supplemental oxygen. I think I was extubated 19 hours after surgery on room air. About 6 months after transplant, I was able to resume playing golf, which was my passion, which I had given up for 2 years, as well as pretty much every other physical activity, including travel. I played most of the summer, and on the last 2 rounds, I was actually even able to walk the golf course for the first time in 5 years, about 15,000 steps each round. Last month, I traveled to British Columbia for 3 weeks for my first significant trip in almost 3 years. I did something there that I didn't manage to do while living in Vancouver for 25 years. I climbed the Grouse Grind. It's a 2.5-hour climb up a mountain hiking trail that's over 3,000 feet vertical, extremely difficult. But it proved to me that despite my transplant, we can still live actively and achieve significant things. Transplant definitely is a second chance to resume a normal lifestyle for me. I've been extremely fortunate in my recovery. I've had no real setbacks, infections, rejections, or significant medication side effects other than some weight gain. I've been able to resume many activities I did before my illness. In my case, it has been a complete success and a life changer, for which I am grateful to my family, my donor family and their family, a terrific surgeon, and the entire team at UHN, the multi-organ transplant team. Thank you.